My name is Dr. Akahoshi Takayuki from Tokyo, Japan. I'm a cataract specialist working at the Mitsui Memorial Hospital in Tokyo. I'm working as an ophthalmologist for 30 years, operating nearly 8,000 cataracts per year. The greatest merit of the small incision cataract surgery, or especially the micro coaxial surgery, is that by this procedure we never produce any surgical induced astigmatism. There's no astigmatism after the surgery. So, and also the rehabilitation of the vision is very quick. The patient can enjoy good vision soon after the surgery. The incision is small, there's less risk of endophthalmitis. For these 30 years, especially when I start to the microcoaxial surgery for these 8 years, there's no single case of the endophthalmitis using microcoaxial technologies. Most important point of the microcoaxial surgery is to protect the incision, and making a very beautiful, clear-cut incision is a key point. Because incision size is small, and even we use a sleeve on the tip, there might be some damage on the incision. So making a clean incision so that it can easily seal at the end of the surgery is very important. So I prefer to use a special diamond keratomes. I designed two diamond keratomes. One is nano keratome and the other is ultra keratome. The nano keratome has a trapezoid configuration. At the shoulder it's 1.7 and at the bottom it's 2. And the ultra keratome has a configuration of 2.0 at the shoulder and 2.3 at the base. My diamond blade thickness is only 100 micron, very thin, so it is very sharp. I use nano diamond keratome or ultra diamond keratome to make a main incision. And also for the side port, I designed a special small diamond knife. That blade is only 0.6 millimeter. The reason why I make a small side port incision is that after finishing the microcoaxial surgery, the incision size is only 1.8. The capsulorhexis is one of the most important points in the cataract surgery, because even if we had a very expensive biometry machine to measure the actual length to decide the IOL power, if the lens is not appropriate position in the capsular bag, we will have the error of the refractions. So the lens should be completely in the capsular bag at the end of the surgery. So I always try to make a capsulorhexis edge on the optic at the end of the surgery. It is very important to get a good refractive result, and also it can prevent the formation of the after cataract PCO formation is blocked if the lens is fixed by good capsulorhexis. Through a small incision, making the capsulorhexis is a little bit challenging. But I modified my uterate capsulorhexis forceps to suitable for the small incision surgery. So using our familiar uterate forceps, capsulorhexis can be performed successfully with some modification of a new instrument. Hydrodissection is very important because I always pre-chop the nucleus. Phaco pre-chop is mandatory or a very important procedure for the microcoaxial surgery, because by phaco pre-chop we can remarkably reduce the ultrasound NH. But to perform the phaco pre-chop, one of the important points is sufficient hydrodissection so that the nucleus can rotate freely in the capsular bag. So I always try to perform the cortical cleaving hydrodissection, and my hydrodissection cannula is very useful for this technique. It is a 27 gauge cannula, a little bit bent, and also the tip of the cannula is tapered. So it is easy to introduce under the capsulorhexis edge, and also this same cannula can be used to seal the incision at the end of the surgery. Another small important trick and important point for the hydrodissection is to use a small syringe. if you use a big syringe, 5cc syringe, you cannot perform the easy hydrodissection. If you use a 2.5 or 3cc small syringe, you can easily perform the hydrodissection. Phaco pre-chop is a procedure to divide a nucleus prior to the phaco emulsification. It is an old technique I developed nearly 20 years ago, and all my cataract procedure is performed using pre-chop. By pre-chopping the nucleus, the total ultrasound energy can be remarkably reduced, maybe less than 10% of the conventional divide and conquer techniques. By pre-chopping the nucleus, each pre-chopped nuclear fragment can be quite easily phaco-emulsified, even beginners of the phaco-emulsifications. The total energy is less and the total surgical time is less. During the phaco-emulsification, especially for the microcoaxial surgery, we need to higher the bottle to pressurize eye to maintain the stable anterior chamber. But if you take time during the phaco-emulsification, there is so much pressure in the eye and it may damage the optic nerve. But once the nucleus is pre-chopped into small pieces, we can remarkably reduce the aspiration time. So we can easily and shortly finish the phaco-emulsification. So there is no damage of the optic nerve, and also there's no damage on the cornea endothelium, and also the phaco time and also the surgical time is less. There's less incidence of the infection during the surgery. Any kind of the nucleus can be pre-chopped using vertical karate technique or the counter pre-chop technique. I just use only 2 pre-choppers. If you have 2 pre-choppers, combo 2 or universal 2, we can manage all kind of the nucleus. But those who start to perform the phaco pre-chop, I recommend to start from the karate technique. It is very easy and everybody can perform quite safely. I recommend to start from the grade 1 or grade 2 soft nucleus. Please start from the vertical karate technique using a combo pre-chopper. The combo karate technique is quite easy. The position of the insertion of pre-chopper is just the center of the nucleus, and direction of pre-chopper insertion is just downwards. Pushing the nucleus downwards, open the blade slowly, everybody can pre-chop the nucleus. If you have any difficulty to insert a blade into the nucleus, it is not a good candidate for the karate technique. You should not try that. You should convert to the counter pre-chop technique. So those doctors who first try the pre-chop should start not dense nucleus. Start from grade 1 or grade 2, and gradually you can try on the denser cataract. I tried any kind of the phaco tip. Especially when I start to use Ozio torsional handpiece, because the tip oscillates like this. The round tip oscillates, there's nothing happen. So I designed the tip, the lateral part of the tip plays important role for the torsional motion. So if I modify the tip overall, I can get more cutting edge on the tip. If I modify the tip square, the flat surface can maximize the cutting efficiency. So I tested clinically several different designs of the tips and found that the square tip is an ideal tip for the torsional phaco. And also my invention is that the off-centered tip. All the phaco tip used to exist in the world was coaxial. The shaft and aspiration port was on the coaxial. But if I place the shaft eccentric to the aspiration port, if I put this tip on the torsional handpiece, it can create a wobbling motion. It can enhance the efficiency of the phaco emulsification. According to my clinical data, not only the soft cataract, but also the very dense cataract can be effectively removed using this wobble tip. And the wobble tip is effective not only for the torsional handpiece, also for the conventional longitudinal phaco handpiece. It can create a wobbling motion at the tip. So compared with the conventional coaxial phaco tip, it can be more efficient phaco tip. Another important point for the phaco tip to use after pre-chopping the nucleus is that I always use my phaco tip bevel down so that I can make a complete occlusion of the tip toward the nucleus. I mainly use a vacuum to remove the cataract, and only when the tip is occluded and clogged, I use a small amount of the ultrasound energy for the purpose of clearing the tip. But if you use a Kelman tip, the Kelman tip is bent against the bevel. So if you try to make a complete occlusion of the Kelman tip toward the nucleus, there is so much stress on the incision. And it may damage the incision by the it may cause the thermal damage or the mechanical damage. So the Kelman tip is not suitable for the phacoemulsification after phaco pre-chop. So I designed a new tip. The tip is bent toward its bevel. So with this reverse Kelman tip, I can easily make a complete occlusion of the tip toward the nucleus, and the tip shaft is parallel to the incision. There's no stress on the incision, so there's no mechanical or thermal damage, and I can make a complete occlusion, so the total ultrasound energy can be less. So with this reverse Kelman tip, I have a bubble design or the square design also. The conventional IA tip, the outer diameter of the IA tip was 1 mm, but through 1.8 small incision, it is not comfortable to move around such a big IA tip. So I designed a special small IA tip. The outer diameter of this tip is only 0.7. So through this small incision, I can easily move around the IA tip. Especially my curved IA tip, it is curved like this. It's an ergonomical design. I can reach any part of the capsular bag quite easily, and even under the subincisional cortex can be removed quite easily using this new IA tip. I have the ball IA tip. The aspiration port of the ball IA tip is drilled 45 degrees to its main shaft. So I can easily make a complete vacuum of the posterior capsule. The posterior capsule can be perfectly polished with this ball IA tip safely. With the ball IA tip, the tip is curved or bent. It is not necessary to move around. It just by rotating the tip, I can reach many parts of the capsular bag, and the cortex can be quite easily removed. Even though I could successfully remove the cataract through 1.8 mm small incision, if I cannot implant the good intraocular lens, there's no sense. So I developed a technique to implant this 6 mm optic acrylic lens through this small incision. This technique is called counter-traction implantation technique. With the conventional monarch screw-type monarch injectors, we cannot provide a counterforce to the eye. So I designed a uni-hand syringe-type injector called Royale. To implant the lens through a small incision, we need some sort of the counterforce to the cartridge. As we have only 2 hands, we cannot screw the plunger, and I don't have a third hand to fix the eyeball. So as we don't have 3 hands, the counter-traction implantation using screw mechanism injector is not possible. There's no challenge in my cataract surgery. If I use these new instruments and new techniques, the cataract surgery can be performed quite easily and quickly and safely. I can operate more than 60 cases a day. Usually I operate more than nearly 60 cases. I can operate more than 12 cases per hour. All the procedure is performed through sub 2 mm incision, and I can implant toric or multifocal lens through this small incision.